let us have him on the stage. CHUKWUEMEKA NNAJI is a certified dental therapist and a member of this college, Orapo College of Scholars. He is currently working at Akwa Ibom State Polytechnic Medical Center, Ikotekbene. And his topic today is management of post-exodontia hemorrhage. Please ask CHUKWUEMEKA NNAJI, are you on? If you are on, the stage is yours. Thank you.
Yes, please. I'm on. I want to apologize for the break in transmission. There really feeling a very poor network here. I hope you can hear me now.
Very well, we can hear you, sir. Go ahead.
All right, please. So we begin all over again. The presentation outline is as follows. Introduction, epidemiology of post-exodontia hemorrhage, causes, characterization, categories, and finally, management. So we move to introduction. It is not abnormal for a tooth socket to bleed after a dental extraction. However, if the bleeding persists for more than 12 to 24 hours or lasts for days, then it is known as post-exodontial hemorrhage. This condition is a well-known and common complication in dentistry and has been defined as bleeding that lasts longer than 8 to 12 hours following the tooth extraction. The percentage of people who experience this condition ranges from 0 to 26%. So let us look at the epidemiology of post-exodontial hemorrhage. A study found that the male to female ratio in this condition is 2 to 1. That is to say that the condition occurs more in men than in women. Also, it is more common for people between the age of 21 to 45 years. And there is a personal or family history of post-exodontial bleeding in 25% of cases that has been reported so far. This condition occurs at a rate of 0.6% after the extraction of lower third molars and 0.4% after the extraction of upper third molars. Jensen, 1974, examined 103 cases of post-operative prolonged bleeding following oral surgery and found that 75% of the cases developed within 8 hours of surgery, with just 4 patients having coagulation abnormalities. He also reported that post-operative prolonged bleeding from the mandibular molar is more common. This is probably because the floor of the mouth is highly vascularized. That is to say, the floor of the mouth has more blood vessels and more vascular supply than the upper part of the mouth. Wells et al. 2000 noted that the risk of prolonged bleeding in cases of third molar removal surgery ranged from 0.2 to 1.4%. Iwabuchi et al. 2014 found a 2.77% clinically significant post-exodontial hemorrhage in warfarin therapy patients and 0.39% in non-warfarin therapy patients, regardless of tooth type. In a cohort study conducted by Kotoka et al. 2016, the incidence of this condition ranged from 0 to 26%. patients on direct oral anticoagulant and vitamin K antagonist both had the same risk of post-exodontial hemorrhage. Having looked at the epidemiology of this condition, let us now consider the causes. This condition can be triggered by drinking through a straw, spitting, or smoking after extraction. It can also be caused by rinsing or gargling 24 hours within the extraction. These activities create negative pressure within the oral cavity and remove the clots from the extraction. The causes of post-exodontial hemorrhage has been attributed to two major factors. One, local factors, and two, systemic conditions. Local factors may cause or trigger soft tissue bleeding or bone hemorrhage. Conditions which cause soft tissue bleeding include trauma, laceration, friable granulation tissue, clot dislodgement, infection, hemorrhagic lesions, violent exercise, application of heat, and coughing. While bone bleeding might happen in the canals or in the central vessel. So let us look at the systemic factors or systemic conditions that can trigger post-exodontial hemorrhage. Some of these conditions include hereditary or acquired disease such as vitamin K deficiency, prolonged steroid therapy, platelet anomalies, lupus erythematosus, liver dysfunction, chronic liver failure, uremia, multiple myeloma, which is cancer of the plasma cells, leukemia, hypertension, excessive fibrinosis. We also have coagulopathy such as inability of the platelets to clot, thrombocytopenia, and so on. If this condition is not controlled, it might lead to complications, further complications ranging from soft tissue hematoma to significant blood loss. Let us now look at how post-exodontial hemorrhage is characterized. This condition has been characterized as either mild. When you say it's mild, that means it's just oozing blood, or as moderate. Moderate refers to bleeding that remains on the second day after extraction, or as severe. Severe refers to any bleeding that needs hospitalization. Let us look at the categories now. Post-exodontial hemorrhage has been categorized as 1. Primary prolonged bleeding, 2. Intermediate or reactionary prolonged bleeding, and 3. Secondary prolonged bleeding. The primary prolonged bleeding occurs during the extraction procedure and may be due to traumatic extraction leading to laceration of the blood vessels, infections such as apical granuloma, or injury to the bone. Patients with primary prolonged bleeding present with their mouth actively filling with blood immediately after removing the hemostatic dressing. The intermediate or reactionary bleeding happens a few hours after extraction, and it is more likely in patients with systemic disease or those who are taking anticoagulant medication. Secondary bleeding occurs 7 to 10 days after an extraction and is a rather uncommon complication in dental treatment. Having looked at all of these things, let us now discuss the management of post-exodontial hemorrhage. The management of this condition is an indispensable skill for dental practitioners. The condition must be managed cautiously and methodically. Multiple factors influence clinical decision-making about how to manage post-exodontial hemorrhage, including the surgical location and site of bleeding, wound size, degree of bleeding, accessibility of the bleeding site, and bleeding time. Furthermore, the choice of an intervention method to achieve hemostasis depends on whether the patient is taking any medication or has a systemic condition such as cirrhosis that can affect bleeding and coagulation. Family history, past dental history such as bleeding, past medical history such as platelet problems related with liver diseases or hypertension, and pharmacological history such as whether the patient is on oral anticoagulants and necessary preoperative measures to observe. Perioperative precautions should be taken, such as careful manipulation of tissues to avoid unnecessary trauma. But if a patient presents with hemorrhage, the following should be done. 1. Rapidly assess the patient's general condition. Perform a periodic monitoring of the patient's vitals for the signs of hypovolemia. 3. Wash the patient's mouth with cold water and remove adherent cloth with a gauze swab. 4. Apply manual pressure or put a gauze over the area. This will certainly stop generalized oozing from the soft tissue. Tannic acid powder can also be used to stop bleeding. Sutures can be used across the sockets. If manual pressure fails to achieve hemostasis, it is obvious that the hemorrhage originates within the bony cavity. In such cases, socket pack like whitehead varnish on ribbon gauze or some absorbable hemostatic agents such as gelatin sponge or Surgicel or bone wax may be applied over the site of hemorrhage. The bleeding vessel can be compressed by crushing the overlaying bone with a blunt instrument if a large vessel is involved. If a large vessel is involved, vessel ligation is required. The patient should receive supportive treatment, including warmth, administration of fluids by mouth, drugs to relieve anxiety and pain, intravenous administration of crystalloids, colloids, and then administration of calcium gluconate injection intravenously, and then vitamin K and C. In conclusion, management of post-exodontial hemorrhage is an indispensable skill for dental professionals. Prior to dental extraction, necessary preoperative and perioperative measures should be observed. Nonetheless, if a patient presents with post-exodontial hemorrhage, the condition must be managed cautiously and methodically. These are the references, and thank you for listening.